Good morning, good afternoon, and good evening, everyone. My name is Olive Kokeman, and I welcome you to our webinar series, Lessons Learned by the Network Countries in their efforts to build and institutionalize systems to sustain and scale up quality of care for maternal, newborn, and child health. This is a webinar series organized by the Network for Improving the Quality of Care for Maternal, Newborn, and Child Health, supported by the World Health Organization and Unicef. The objective of this series is to share the progress made by the network countries and lessons learned in their efforts to date. Over these 3 weeks, we've been sharing the lessons from 3 countries of the network, from Ghana, from Tanzania, and today is Bangladesh. The network countries, 11 in total, set out in 2017 with 2 goals: to have maternal and newborn mortality in health facilities by 2022, and to improve the experience of care under the 4 strategic objectives of learning, accountability, leadership, and action. So we have the 3 webinars per country over these 3-week period. Please join us next week as well for Tanzania. And we will finalize this series with the launch of the Network Progress Report, sharing progress across all the countries on May 4th. So it is my pleasure to hand over today to Ted Bab Gabriel, who is Senior Advisor for Health at Unicef Headquarters, who will introduce us to the content and the speakers today.
Thank you, Olive, and welcome again, colleagues, wherever you are. Good evening, good afternoon. It's a pleasure to have you, and thank you for choosing to be with us this morning. So as Olive said, this webinar today will be looking at how Bangladesh has built a system to sustain and scale up quality of care, starting from one learning district and taking to scale. So today we will hear this experience of improving quality of care in Bangladesh, as I said. Next slide. So today, I am honored to facilitate this webinar with my colleague, Dr. Rajesh Mehta, who is the Regional Advisor for Newborn, Child and Adolescent Health in WHO Regional Office for Southeast Asia. And we have also 3 colleagues from Bangladesh. We have Dr. Mahmoud Khair Islam, who is the Program Manager for Newborn Program and IMCI from the Directorate General of Health Services at the Ministry of Health in Bangladesh. And also Dr. Zia Matin, who is my colleague at Unicef, is the Health Manager in Bangladesh Country Office. And Dr. Mamoon Brian, who is the Quality Improvement Implementation Advisor at IHI, USAID's Mamoni Project, Maternal and Newborn Health Care Strengthening Project. Colleagues will share the experiences, lessons learned, and the recommendations. So the first presenter will be Dr. Zia, who will take us into the design, the implementation, and the results of a learning project in one district in Bangladesh. The floor is yours, Dr. Zia. Just to give you at a glance what we will be discussing today is we have 3 parts. The first is the introduction part, where we look at the national strategy and engagement. In the second part, the specific district learning district project. And the third, we will see what lessons were learned through this, from one district implementation and also the other, the Mamoni project. And then lastly, we will see the lessons, the recommendations, and we will conclude with questions and answers, who will be facilitated by Dr. Rajesh. In the meantime, while the presenters are going through their presentation, I encourage you to type your question into the chat box, and we will address as the session continues. Dr. Zia, now is your time.
Thank you very much, Ted Bab, and thank you all. Good afternoon, good morning, good evening, everyone. It's been a pleasure to be here and present the experience of Bangladesh. So I will share with you, as Ted Bab mentioned, some of the experience from Bangladesh, how the Ministry of Health and its functionaries, they improve the quality of care for MNCH. through modeling of these in a few learning districts. And that actually helped the Ministry of Health, particularly at the sub-district level, for scaling up the quality of care for MNCH and also building the system for it. Next slide, please. As you know, Bangladesh has achieved kind of a significant progress in improving the coverage for many of the MNCH indicators. Uh, uh, Although there were some hiccups during this ongoing COVID pandemic, but in terms of some of this coverage, Bangladesh achieved significant progress. However, there are still some challenges when it comes to these reducing the neonatal and maternal mortality. We are observing some kind of stagnation there. At the same time, there are opportunities that I have already mentioned in terms of improving the coverage of many of the indicators, and particularly in progress of reducing the child mortality, as Bangladesh has almost kind of reduced 79% of the child mortality in the last 1 decade. Next slide, please. As I will be more talking about these immense quality of care modeling in Kurigram districts, it has been very much aligned with these quality of care, the QD framework that Olive was showing, the leadership, action, learning, and accountability. So I will touch upon on those areas later on in my presentations. Next slide, please. And in this quality of care initiative in One Learning districts, the Ministry of Health and its department at the sub-district, at the district level in Kurigram, they have taken efforts to introduce 9 quality of care standards in the domain of clinical care, patients' rights, and cross-cutting issues. Next slide. As I was talking about the situations in Bangladesh, almost 68%, there has been 68% decrease in neonatal mortality between 1990 and 2018, but still there are 17 neonatal deaths per 1,000 live births in Bangladesh. Next slide. So now I will give you some kind of glimpse of the policy and strategic environment in Bangladesh. So far, we are having a very kind of a permissive policy environment when it comes to the MNCH, particularly these quality of care initiatives here by the Ministry of Health. There has been a lot of strategies and costed actions plan developed for the maternal and newborn health. We have the National Newborn Health Program that was kind of integrated in the ongoing health sector programs in 2017. That has actually steered the whole newborn health program and the newborn, the priority implementation of the priority newborn interventions across the country. So many guidelines and modules has been developed, particularly these every mother, every newborn quality of care standards that was actually kind of adapted in the country with engagement of all the expert group, the Ministry of Health, the stakeholders, as well as the professionals and academia. And also the MPDSR national guidelines and tools were developed and implemented and introduced in the program. Next. When it comes to the leadership accountability, the Ministry of Health has formed this quality improvement secretariat. So that is a kind of a significant steps taken by the Ministry of Health because it is nested within the Ministry of Health in the Health Economics Department. And they're kind of giving the policy strategic directions, as well as when it comes to any strategy or guideline development, even the modeling of these different initiatives. So they gave all this stewardship and the guidance to this quality improvement program in Bangladesh. At the same time, the Ministry of Health has formed many QI coordination structures from the national level to the subnational level up to the facility level. And those are kind of functioning, and that has kind of happened during the last few years under the leadership of the Ministry of Health and the DGHS and DG planning. And these, I was talking about this immense quality of care modeling in one district, Kurigram, and also there has been another model that that is being implemented in Manikganj by the Mamuni USAID initiative. So these integrated QI model was implemented in these learning districts stewarded by the Ministry of Health, the QIS, and the program. And there has been a consensus among the partners and the Ministry of Health and all the stakeholders on taking forward implementation of the WHO QI framework and operationalizing the MNH quality of care standards. So now we are gradually moving from this MN quality of care standards to kind of embrace this MNH standards of the WHO, and we have that agreement among the stakeholders and all the partners to take it forward for implementation. And there has been coordination and harmonization of the partners supporting in 17 learning districts right now under the guidance of the QIS and DGHS. And all the partners and the Ministry of Health, they are kind of giving implementation support to the district and facility level. The ministry is giving that support through their operational plans of the Directorate of Health Services under the 4th Health Sector Program. There has been on-site monitoring and QI learning system that has been established by the Ministry of Health and the DGHS and the different directorates, and those are functioning, particularly in the learning districts. And a significant step was this strengthening the measurement system, because all of you know, we have a very rich MIS system here, the functioning DHIS2. And the steps that we took is to integrate the QD indicators in the DHIS2. So all the QD indicators are now integrated in the DHIS2 platform, supported by all the partners. Next. Now I will focus on some of these action and learning. So I will take you to this MN Quality of Care initiative and share some of these findings and results from that initiative that was modeled in Kurigram learning districts. Next. So this Every Mother, Every Newborn Quality Program initiative that were implemented while the WHO standards for improving quality of maternal and newborn care in health facilities were being developed. So at that time, WHO was developing that, but we adopted very quickly these MN quality of care standards, and we work with the Ministry of Health and its functionaries at the district level to implement this model that also informed WHO, Unicef, and other partners in finalizing these MNH quality of care standards. And it focused on 3 major areas: reducing maternal newborn fetal deaths and severe morbidity, improving access to services, and ensuring the safety of mothers and newborns. Next slide. The intervention package that was covered under these MN quality of care initiatives in Kurigram, one of the key area was the infrastructure building, building the kind of facility readiness, increasing bed capacity, establishing the newborn care unit, the special care newborn unit, what we call the SCANU, the newborn stabilization unit at the sub-district level, and also in all facilities with the KMC units, and also procuring the equipment for facility readiness. The second area that the MN model focused is institutionalizing the quality improvement in terms of forming the QI teams in the facilities, functioning of those teams, in supporting the facility team for quality improvement of MNH services, support for training, placement of human resources under the local level planning initiative, the training, mentorship, coaching support, the periodic quality of care assessment, both by the national assessor team as well as the district assessor team, then MPDSR, the maternal parental death review, surveillance and response, and also strengthening the HMI system. And when it comes to the implementation, it covers this infection prevention and control, the WASH in healthcare facility. Actually, this WASH was integrated through this MN initiative in Bangladesh, and now we have scaled it up in another 15 districts. The labor monitoring, postnatal and newborn care, community engagement. So the community engagement was done through the existing government structure and platform, ensuring the privacy, the triaging, and the referrals. Next. So this MN quality of care model was implemented during 2016 to 2018 in 5 facilities. 1 was district hospital, and 4 was sub-district hospital, which is called Upazila Health Complexes. And this Kurigan district is in Rangpur division. So among one of the 8 divisions in Bangladesh. Next. Evaluation was also commissioned during this implementation period. So we have a kind of 2 round of assessment. One was before the intervention started, and then at the end of the interventions across 18 months. The objective of these assessment was to assess the effectiveness and document lessons learned. One of the objectives was to assess the structural readiness, human resources, healthcare provider skills, equipment, and supplies. The second objective was to determine the extent of institutionalization of QI standards, integrity, and progress of implementation. And objective 3 was to examine improvements in perinatal clinical outcomes for mothers and newborns. And the fourth objective was to document and describe key lessons learned to inform implementation of the MNQI model. Next. So in terms of the findings, when we implemented these MNQI model over this period of 18 months, the total births that was recorded more than 7,000. The total newborns that were admitted for special care almost 5,000, more than 5,800. Almost 48 mentorship visits kind of occurred there, and 147 QI coaching visits were conducted in those facilities. Next. Now I will share with you some of these findings from these 5 facilities during this 18 months period. Next, can you click once? So in the domain of the respectful care, we saw some substantial increase in this area in terms of respectful care. You can see here in the graphs, the women's concerns considered during the care, it increased from 56% to 75%. Whether the consent was taken for C-sections from all the women, it also increased. And then whether the women felt satisfied with the care, it increased from 66% to 94%. Whether the woman will return to the facility for next delivery, yes, it was also increased from 63% to 85%. And when it comes to the total examination findings, it increased substantially, and also, yeah, next slide, please. I think I covered this slide already. In the area of the maternity care, substantial increase in practices around the management of labor and delivery. You can see in the left side, the graphs, whether the documentation was done in terms of the blood pressure taken. It increased significantly from 33% to 95%. Whether oxytocin was administered within 1 minute, it increased from 73% to 96%. Whether labor was monitored through partograph, it increased also substantially. It was a kind of nil when the initiative started, but it increased to 34%. Whether the fetal heart auscultation was done, it increased from 8% to 72% in all these 5 facilities during this 18 months period. And whether examination was done, the abdominal examination was done, it increased from 51% to 82%. So some of these practices which were nearly non-existent, that also saw some increase during the implementation period, as I already mentioned. Next slide, please. So coming to the newborn care, also in the newborn care, substantial improvement in terms of readiness and provision of early essential newborn care. You can see here in the graphs, the delayed cord cutting, it has increased from 65 to 75%. The weighing the baby, it has also increased. Whether the baby was assisted to breathe, it increased from 45% to almost 100%. This is a significant improvement here. The early initiation of breastfeeding, that also increased, as well as the skin to skin. And one of the critical kind of element here was the establishment of the special care newborn unit in the district hospital, as well as the KMC services in all the 5 facilities, along with the newborn stabilization unit at the sub-district level. Next slide. Okay, So some of the findings regarding some of the standards that need further improvement that we have observed is the standard 2 in terms of the health information system and using the data to ensure early appropriate action to improve the care of every woman and newborn. And another standard that required kind of more attention is every woman and newborn with the conditions that cannot be dealt with effectively with the available resources in terms of the referral. And also the standard 6, every woman and her family are provided with support that is sensitive to their needs and strengthens the woman's capability. So these are the kind of few standards that require more attention and more system support that we observe during this implementation period. Next slide. We also observe some improvement and some effect on the mortality. The neonatal case fatality rate fell from almost 9.9% of admitted cases to 6.7% after 18 months of implementation. While in comparison facilities, there were 10 facilities, comparison facilities. There was a decrease from 8% to 5.9%. Also, the stillbirth rate had a marginal reduction from 44 to 42 per 1,000 live births. Next. So that was the presentation from me. Now I will hand over to Dr. Mamun Bhuiya, who is the QI advisor, USAID's Mamuni MNCSP. So over to you, Dr. Mamun. Thank you very much.
Thank you, Dr. Jia, for your nice presentation. And now me and my colleague, Dr. Muntasir Moin, welcome you all from USAID Mamuni MNCSP and Institute for Healthcare Improvement. Next, please. Here I am taking the opportunity to introduce with the USS Mamuni MNCSP strategic objective and results. You know, Mamuni MNCSP embraces the GOB vision and meaningful contributing to achieving the goals of reducing the maternal mortality ratio and neonatal mortality rate during the project life. And Mamuni MNCSP intends to achieve its strategic objective of increasing equitable utilization of quality MNC services for intermediate results that have been implemented synergistically to strengthen district level capacity, improve the quality of MNC services and quality of care, governance, improve access and demand for MNC services, and improve GOB's capacity to deliver quality MNC service at a scale. To keep these pieces moving around, Mamuni is closely working with Ministry of Health and Family Welfare, both at national and district level. Next, please. So as I said before, Mamuni is attached to district level, and for the QI, we are moving with care and operational bundles. And I am very much sure you all know this, but I wanted to share a quick slide on the definition of the bundle and why they are important. A bundle is a set of best practices which, when considered together, improve a whole process and draw greater well-being for the beneficiaries. Very straightforward. And we found that bundles are more effective with providers as they relate more to one or an all or none concept. There is a difference between improve the compliance of measuring only urine albumin during an ANC visit and measuring 5 components, all of which must be looked at all the time for it to be classed as proper ANC visit. Providers relate to this component more reliably, and it is harder but more meaningful. So providers use improvement cycles to best change ideas to determine what interventions they need to put on in place to ensure compliance with all the components. They themselves track data weekly and apply on a run chart. And in Bangladesh, we have also applied this same concept to operational areas which addresses more of the experience of care elements. On the left side of the, you can see an example of ANC bundle. There are 5 minimum components which must be addressed to comply with the processes. Next, please. And here is a slide shows you the bundles that we have developed as a part of the process in Bangladesh. We decided to take a holistic approach by defining the continuum of care and then developing the most relevant bundles at each phase. We designed clinical bundles initially, but when felt we need to go beyond provision of care to an important aspect, very, very important aspect, that is experience of care. So we added operational bundles into the bucket. Next, please. So one of the good approach of these bundle activities or QA activities, that is learning by doing. Creating that supportive environment helps the folks to build confidence, and confidence is very, very much important to such kind of activities. Once the providers are confident and they understand what the work they are doing is not the project driven activities, rather than it is a part of their daily work, they start to own this. And in the areas where this has been possible, we have the strongest result. Next, please. So now monitoring and demonstrating results are an important aspect of this work stream. Providers need to see how they are performing to understand which areas to improve on. And for this, unfortunately, there is some extra work to do. However, now let us look at some results. On this slide, you can see two graphs where we are showing collaborative data for facilities across districts. Providers collect weekly data and then plot their own data on an annotated run chart. Though these slides are not showing those things. So audits are carried out through the systems by subject matter specialists or consultants or any available person who can lead the program. We collected baseline, which is 7% for quality ANC and 0% for current photograph use. From the records, that was low evidence that the 5 essential components of antenatal care as per the maternal health SOP in Bangladesh was not being carried out. When discussed, providers stated that as long as there was an ANC visit, they thought it was enough. However, we helped them to open their eyes. We oriented them on the bundle explained. All the elements, things started to change. On the graph, you can see that we are still not at 100% across all participating facilities. Some have issues with logistics, other miss areas when the load is excessive, and some simple forget. Each facility has their own annotated run charts, which they produce, and they use this to constantly monitor their performance. Currently, 68 facilities across 6 districts have been implementing this quality ANC bundle. And this quality ANC bundle helps the providers to identify the high-risk mom with severe anemia and high BP, and are able to take prompt actions to tackle their health risks. To correct use of part of the bundle had some similar challenges, be it the provision of the simple partograph paper or training on the use of partograph. However, we found that once they understand, providers really try to adhere to the principles and apply their learnings. Our current vision is 73%, and our performance is over 90%. More facilities will be taking on this bundle. However, currently 23 facilities across 6 districts have been implementing it. Next, please. Here's another bundles that we call delivery bundles, and 11 facilities are currently moving with these bundles. Next, please. So this is quality essential newborn care bundle. This graph demonstrates the compliance with essential newborn care from 12 facilities. This is collaborative data. This is a bundle that some providers have struggled with, especially skin-to-skin contact. Facilities have been considering many change ideas as to how they can make this happen. The Ghanaian consultants, as the QA leader, took the initiative to ensure that skin-to-skin contact took place for C-section also, not only the vaginal delivery. This consultant led approach engaged the nursing teams and monitored and support staff to make this happen all the time that I mentioned earlier for creating the enabling environment. Next, please. So this is this slide. You can see some data from last 8 months on newborn mortality and stillbirths. This is the data from a district where we started work in May 2019, initially with correct photograph use, and further bundles were added subsequently. And from this data, we can see a downward trend for mortality and stillbirths. Next. So this is our scale-up plan. We started initially with 12 facilities in Manikganj. Now, currently, we are in 86 facilities across 6 districts in Bangladesh. And the plan is to scale up to 197 facilities by the end of this year. By the by, Mamuni now is working in 10 districts. And from this year, Mamuni extended its geographical area to 17 districts. So our scale-up plan also touches those places also. And from the scale up, you can clearly see that this COVID situation couldn't stall the inflation or scale up of these QA bundles. Next, please. So All of these efforts mean that we can provide right place and the right care at the right time, all the time, and embed within through the system. If we could open our eyes, if we could open our hearts, and if we could uh, open our visions. Thank you, everybody. So uh, now I would like to invite my next speaker, Dr. Sharif. Thank you, everybody.
Thank you all. Many thanks to my colleagues, Bangladeshi partners, Dr. Jiaul Motin and Dr. Mamun for their excellent informative presentation. The following slides, what I'm going to present are about the lessons learned from quality improvement initiation packages and recommendations based on experience. First slide, please. Yeah, okay. Leadership is the key to success. A good manager can involve all stakeholders, professional bodies, academia, and make excellent public-private partnership to achieve fruitful result. Strong leadership translates policy and guideline from macro level to micro level for successful outcome of a program. Next slide, please. Next slide. Okay. To save valuable lives as well as to achieve sustainable development goals in due time, we need to strengthen quality primary healthcare services, which can be achieved if quality improvement interventions implemented appropriately. Next. Quality of care should be the entry point of broader health system improvements, improved quality and use of data to inform changes are bedrocks for system resilience. Next slide, please. Okay. There is no alternative of skilled ASR. Gaps in skilled human resource are a threat to sustained progress. Regular on-job training, coaching, mentorship is the key to retain skilled ASR, and it is needed to integrate in national strategy. Next slide, please. Data evolves during quality, and early improvements in outcomes may be masked by concurrent improvements in data capture. Next slide, please. And a result of the quality improvement to build platform to achieve further improvement. It is a continuous process as substantial challenges remain in quality of care for mothers and newborns. Next slide, please. The following 5 points we recommended on the basis of lessons learned. The first recommendation is the Ministry of Health and Family Welfare, Director General of Health Services, and the Quality Improvement Secretariat should facilitate rollout of the quality improvement packages across all facilities in the country. And this will require further strengthening and systematic institutionalization at the national and district levels. Capital investment for procurement of key inputs are required and need engagement with key partners. And the recommendation, second recommendation, we suggested that human resources for health are poorly available and may threaten the sustainable of the momentum and system-wide improvement. The Ministry of Health should address this at the national and local levels as well as immediate critical challenges. And third recommendation, we suggested that the Ministry of Health and partners should develop strategies to ensure equipment is used for providing care by training technical staff on equipment operation as a short-term priority. This should be followed with support for installation and maintenance of equipment through bioengineering departments. Next slide, please. And the recommendation number 4, the community engagement at the micro level must be prioritized with support from macro level. And this will require resources and greater intersectional collaboration of all levels. This will make quality healthcare that responds to need a valued community asset. And the final recommendation is the Ministry of Health should ensure that standard operating procedures for referral of maternal and newborn Complications are available in all facilities to standardize and guide practice. Two-way information follow. Follow for referrals is critical for continuity of care. Next slide, please. And in conclusion, we can say that implementing the quality of care standards is feasible in low and middle income countries. Implementing quality of care standards in facilities is necessary to improve health outcomes. And the third one is sustaining results will require system-wide change and significant technical support. And based on these lessons learned from these two pilot learning districts, we feel that the quality improvement initiatives is effective, which can be scaled up. Already, the intervention is working in 32 districts covering 205 facilities, which includes district hospitals, sub-district hospital, that is Upazila health complexes in Bangladesh, and some union health and family welfare centers. We need to scale up quality improvement initiative throughout the country with the government operation plan. These are all from my side, and next slide I want to acknowledge those who are participating, that we would like to recognize and appreciate contributions, partnership, and support from Minister of Health and Family Welfare Bangladesh, district management teams and implementing facilities, professional associations and academia, the Obstetrical and Gynecological Society of Bangladesh, the Bangladesh Neonatal Forum, Bangabandhu Sheikh Mujib Medical University, and also I want to acknowledge other partners like WHO, UNFPA, USAID, Save the Children International, ICDDRB, Health Team of Unicef Bangladesh, Bill and Belinda Gates Foundation. And this is all from my National Human Health Program and IMCI. Thank you all. Thank you.
All right, so thank you so much. I must admire the presentations by all three speakers. Dr. Zia from Unicef Bangladesh, Dr. Mamoon Bhuiya from the Mamoni team in Bangladesh, and Dr. Islam from the Ministry of Health. And they have been so efficient that we have a good time to actually discuss the question and answers. And I'm grateful that Mamoni team, we had Dr. Muntakir trying to address some of the questions in the chat box, and some answers have been provided. But I still have a list of questions. But before that, I must also remind ourselves that today is the anniversary of WHO, and we are celebrating World Health Day. The theme being fairer and healthier world. And without quality of care, neither are we fair to the poor people, because they don't deserve poor services. And at the same time, the poor services do not lead to desirable health outcomes. So for building it back better from the pandemic crisis which we have faced, I think it's a good theme to work throughout for fairer and healthier world in terms of justice and overall health and well-being. So we heard a good example, a good evolving story of how a resource-limited country, of course, resources are now improving in Bangladesh. They are doing good economic development. So we were told that the quality improvement is feasible. And we saw that the Every Mother, Every Newborn initiative provided an opportunity to start the work. And they started with 9 standards, but soon enough harmonized into 8 standards of the global MNH. But the standards were then utilized and actions were taken at several levels of health system. And later on, the high quality health system, the Lancet Commission reminded us of actions are required at micro level, meso level, and macro level. And we saw by instinct, even in MNI district, they had to take actions at national level to strengthen the leadership and governance part, the adoption of standards and making some guidelines, and then work at district management level, and then also work directly at the facility level. So a clear demonstration that actions are required at several levels, but you can start from any one or all three together, but there is no sequence for which we should wait. We should start acting wherever it is possible. And then we realized that they were able to demonstrate the 4 strategic objectives of the Quality, Equity, Dignity Network, where we are following the LALA 4 strategic objectives of leadership, leadership, action, learning, and accountability. I think the team pretty well described the leadership, and there was a comment in the chat box from Dr. Kirunda, who mentioned that leadership has been critical in support of Bangladesh QI effort, which was not probably there in his country. With that, the question answer actually highlight, I would pass on these questions to the colleagues who presented. Pritha Biswas has asked Zia that you have used 2 terms, QI mentoring and QI coaching. Are they different? And he wants to know what was actually done in the mentoring visits. If you could quickly clarify that.
Yeah, thank you very much. I think it's a very kind of very important questions, and good questions, I should say. Sometimes, yeah, I mean, it can be confusing looking at both coaching and mentoring, but the way we have designed in this model, we try to see to build the mentorship, because initially we thought of kind of bringing the professionals, because we have this Obstetrical and Gynecological Society of Bangladesh, so they were kind of engaged with this process. So we identified a set of mentor from the national level who actually provided the training on site, because this is quite different from the national program. I mean, the program manager is here, Mohammed Shariful, he knows. All the kind of national trainings are happening at the national level for maternal and newborn child health. But for this model, most of the trainings were happening on site at that level. And this set of mentor went there to provide the kind of the first, kind of set of training. And they again went back there for mentoring, so that happened during this course of the implementation. And that brought some very visible good results, not only in terms of the service, but as well as, the interaction, the kind of guidance, support, not during these on-site training or these the follow-up mentoring visit, but even when they were kind of, remotely, they were in touch. And that brought some kind of visible changes in terms of motivation and the commitment and the spirit among the service provider. That was very much evident. I mean, whenever we visited those facilities, we have seen that. And the coaching was done by the local level district people, because those are kind of the government, the persons there, a set of coaches identified by the local authority, by the local leadership. They are going to the facility for coaching on site for everything, not only the the service part, but also the other QI part.
Right.
I hope I could respond to your question.
Sure. So they were supervising as well as solving problems and providing them solutions to, so if they were stuck at quality improvement processes, probably they would be able to guide them. There is a question about, there is in your presentations from both streams of work, there is a overlap of actions related to quality improvement itself and also the infrastructural strengthening. So the point has been raised that it is difficult to understand whether QI itself led to infrastructural strengthening, or infrastructural strengthening was followed by improvement, or was there a to and fro mechanism which was followed? If you could quickly clarify, because many times it is difficult to, the actions are required for both, right from quality planning to quality improvement and quality control and accreditation. There are several streams of work. In a short presentation, it is difficult to identify. But if you want to say, if there was a bi-directional element between the infrastructure strengthening and quality improvement work at the facility.
Yeah, I mean, thank you. I mean, what happened exactly at the facility level, because when we started this initiative there, the local QI teams, they are kind of identifying the gaps there. They are coming up with an action plan at the WIT level, the work improvement team, for improving the quality of the services. And they identify some of these kind of gaps in terms of the service provision that requires some kind of facility readiness, including these the infrastructure like the SCANO, the special care newborn unit. So that's need to be built there. So some kind of renovations were required there. It coming to this newborn stabilization unit at the Upajala Health Complex. One of the questions I saw, it doesn't require much resources there. To build a kind of NSU, and like the KMC, it doesn't require that much of resources, but they identified those gaps in terms of improving the services, the facility. So simultaneously it happened, so it was kind of addressed by the facility, some of the kind of support given through the system from Unicef and also from the government for this renovation and the other facility readiness aspect. At the same time, they worked on the software, like the projects, the quality improvement projects for improving the quality of the different services there in the facility. Over.
Thank you. Thank you, Zia. For Momini team, there was a observation that 6 districts were following similar processes. Were the improvements also similar? And what were the opportunities of collaborative learning which were offered within the district and across the districts?
So thank you. Actually, Mamuni MSSP has been working with the QI pieces that is more related to the soft part, that is in capacity, capability building, and leadership. So if any QI project introduced or launched in a facility, if the facility is fine, then the Mamuni MSP works with the to help them open their eyes by capacity and capability building, and then establishing the uninterrupted resource supply. So it is very important for our model that must be a platform where all the participating facilities should come together and learn from each other. That is we call a learning and sharing model. So within the district, it is very much possible by using existing government facilities, and also it is possible to demonstrating another district by pulling people champion from this district to another district for their learning and sharing. And it is also possible to at the national level to make them introduce the champions and to inspire others for making examples. Thank you.
Yeah, so there is a clear advantage if you provide opportunities from one team to learn from another. And so one of the learning strategic objectives actually provide for that kind of approach. And then there are some issues which have been answered in the chat box already. So I will not be focusing on that. But in terms of Dr. Islam's summarization of the lessons learned, since there is sometimes a hesitancy or less preparedness in the national level leadership to invest in immediately large-scale quality improvement, what was a different way the leadership in Bangladesh actually decided to do this, starting from Kurigram district? Dr. Islam, if you have some idea, some message to share.
Yeah. For quality improvement packages, to implement the quality improvement packages, we need a good leadership. And where there's leadership is the manager is very good and make collaboration with the partners like UNICEF, WHO, Save the Children, and UNFPA, and they are working good. And they are where their ACER is enough ACER, and their services doing good. But if there is managers are not in some districts, I think except Kurigram and other districts where the quality improvement package is not working, some leadership is weak, that they are not doing well. So if we want to expand quality improvement packages all through the country, we need to include it in the operation plan. Now it is the 4th sector plan is going on, which started from January 2017, and it will continue until 2022. And there is scope to include the quality improvement package in the next operation plan, I think, and the manager, national level manager can take initiative in this regard, I think, with the support of UNICEF, WHO, Save the Children, like this. Thank you.
Very good. So partnership was kind of influential, but the government themselves were proactive. And you are saying now that in the sector plan itself, which is the sector-wide plan for health and nutrition, you will be actually putting in budget for quality improvement work substantially. So which is a good way forward. And then there are a couple of observations. Jeff Smith, for example, noted in Zia's presentation that perinatal mortality reduced also in control facilities or control sites. Is that true, Zia? So what could be the reason?
Yeah, I mean, when we observe this kind of reduction in the intervention, simultaneously in the comparison facilities, there were some reduction, because what happened under the leadership of the DGHS and the DG Family Planning, the program manager knows that under this National Newborn Health Program, all the priority intervention has been scaled up across the country, not only for particular districts, you know. So all those interventions went across the country. So definitely in the comparison districts and the facilities, all those priority interventions were implemented as well. And the capacity building efforts by the Ministry of Health, that also kind of went across the country, particularly for these the priority interventions, both for maternal and newborn. So I mean, those are kind of you know, the factor that probably played in reducing you know, the perinatal deaths in some of these non-intervention, the comparison districts and facilities.
All right. So thank you for that. During our presentations, we did not hear many challenges which were faced. So can both the teams actually try and tell us one or two pressing challenges which were, you know, there and which we were able to resolve for the MNH services?
So could I tell?
Yeah, you can go ahead first.
Okay, so from my experience, I have seen that frequent turnover of the leaders is a big challenge, especially at the district level. So once our leader is convinced and started to own the work, suddenly he became transferred. This is one point. Second point is that HR transfer, again, that is HR related. But another thing is that uninterrupted supply of the logistics. You know, for each and QA activities, three things: man, machine, and material is very much important. So it is very much important to keep the logistic uninterrupted. So so we are facing all this at the same time, but we don't want to stop. We are tackling these things in another way. We are introducing our community support to come in front, local government to come in front to take the responsibility of their facilities of their territory and help to have those logistics, which might be not that much costly, to give the services of the mothers and newborns of their territory. So people are convinced and now coming up. So this is another way. But again, I am saying this from central flow must be established and should be uninterrupted. Thank you.
All right, thank you. So Zia, in your stream of work also, you would have similar challenges of the resource.
Yeah, I mean, yeah, one of the definitely one
level,
of the.
If you could tell us at people level also, why are the health workers interested in this at all, and what keeps them motivated?
Okay, so I mean, before going to that point, yeah, one of the critical element was the HR, the same kind of scenario and difficulty and challenges in Kurigram as well. Although we have achieved some kind of, you know, I mean, significant improvements in terms of quality of care, but the HR issue was there. And as I mentioned during the presentation, some of this local level planning, they manage some of these human resources through this initiative, but that was also kind of phased out gradually when you know, I mean, the government could realize, and you know, the posting of these staff nurse, particularly the staff nurse, is in the hand of the divisional director. So we had a lot of advocacy with the leadership, the district civil surgeon and the divisional director, for posting of these medical officer and the staff nurse. But that didn't solve the whole problem, and then at the national level, we had that kind of advocacy, and we also worked with the Ministry of Health. Particularly the problem was these new priority interventions for, the kind of the small and sick newborn care management in the SCANUS, KMC that require, the kind of adequate skilled service provider. So we also supported and provided technical support for proper organogram in the facilities at different layers. And that was kind of recommended to the ministry, and that is under the considerations of the ministry that I know. So that kind of efforts were taken. And coming to this particular, the person at the on-site, because that is the kind of fundamental to this quality improvement. And there comes the real actions, the learning part, So, I mean, initially this PDCA approach, the 5S or PDCA approach is very difficult to understand. But when during this kind of, these coaching at the facility level with this small group of team at the WIT, it was very useful, because when they were doing this PDCA, the small project, they could learn by themselves. And then they visited the other facilities, the kind of the model facilities, because we have kind of different phases in Kurigram.
Sure.
So they visited the other facilities, they learned from those, the first phased facilities, and then they visited the other district as well. And they have the kind of, during this COVID period, it was very useful through the webinars as well for this learning part.
Very good. So you have used several approaches to keep them motivated, although the teamwork itself was good enough, but you continue to support them. Very good. So now 5 more minutes, but I should ask both the streams, actually, Mamuni work and the UNICEF-led work. Although there are a lot of similarities in approach, the same standard, the guidelines, the leadership of the government, but there are some differences in strategies also. So will there be a way to understand if bundles approach, which started immediately as improvement process, whereas on the other side, it was more micro level, one by one approach probably. Will there be in the end a possibility to understand which one worked better? Zia and Mamoon, if you could tell us if there is a way to measure the comparison.
The way I see here is, the fundamental element is the same,
Yeah.
So even in the Mamuni, the same kind of approach is being kind of followed because we are trying to introduce these WHO QI framework and the standards at the facility level. Correct. And the same kind of PDCA approach of, working at that small team level, those are the kind of same things. The only difference is the bundle approach, so that we're still kind of observing how that evolves. And then definitely we have a technical working group here. And just recently this week, we have a discussions among us how we can kind of harmonize among these different initiatives. So that discussions are ongoing, and definitely we'll work towards that.
Good. So one last question on monitoring. I saw a slide from Zia probably on evaluation. But what are you using in both streams of work? Is the ministry monitoring the quality improvement work or you are following different frameworks? What is happening?
No, I mean, that assessment was done part of this model because we wanted to see the results and some of the process,
But concurrent monitoring, how are you doing it?
Right now, when we have, the ministry has scaled up now in 17 districts, including the Mamuni one, almost covering 127 facilities. It's huge. And as I have mentioned, the QD indicators has been incorporated, and all these QI indicators are now reflected in the DHIS too. So right now, even the UNICEF supported facilities in 15 districts, we are kind of monitoring through, different approaches and different channels, but we are using the data from the system, the DHIS2 platform, because they have this very good HMI system now in these facilities.
Sure. So now also WHO framework is almost available to you. So you can use the opportunity with Ministry of Health to see how do you use and visualize the data which is coming so frequently. So we have opportunities of further streamlining it. So thank you so much for all this. And, we are at the point of time now. There are some more questions, but maybe we can try later. But it's my duty to thank all of you once again and hand it over to Olive for the closure. So thanks a lot once again. Well done.
Thank you.
Oh, thank you so very much, Rajesh, to Zia, Mamoon, Dr. Islam, and Tedbab for your leadership and for your excellent session today. Thank you, all of the participants, for joining and for all of your questions. We have established a community of practice. You'll see it on the screen here. If you join this link, we'll share the questions that didn't get to be answered today as well, and we'll follow up with our presenters to help answer those questions further. And we welcome you to participate in the community of practice, pose further questions, and share your experiences there. As we said, this is a series, so join us again if you hopefully can. Next week, we will share the experience with the Ministry of Health Tanzania. You can register at the link. And of course, we will have that further webinar on May 4th. Thank you. There's our website link, and we will be sharing the recording, the slide deck, and all documents from today with all participants and on our website this week. So thank you so much for your participation, and have a lovely day.
Thank you.
Bye.
Thank you all.
Thank you. Bye.
Thank you so much.
Thank you. Bye, everybody.
Thank you. Bye, everybody.